And for many of these conditions now, either clinical evidence or preclinical evidence would suggest that some exercise is definitely good for most of these conditions. It's just a matter of how much.
With the new year just around the corner, many of us are thinking about resolutions, especially when it comes to moving more and taking care of our health. If you've ever wondered what you can and cannot do for exercise, this episode is designed to help you feel more informed and confident in conversations with your doctor. A longtime friend of the Canadian SADS Foundation, Dr. Hamilton is a cardiologist and clinical scientist at Sick Kids Hospital in Toronto. He investigates inherited, congenital, and acquired heart rhythm conditions in children and young adults. This is the first of a two-part conversation on exercise and SADS conditions. In this episode, we focus on exercise guidelines with Dr. Hamilton, followed by a second episode next month featuring Janet Omstead, a health coach and behavioral change specialist who helps translate that guidance into motivation to move and play. As everyone's SADS condition is unique, we recommend speaking with your doctor before starting any exercise program. With that said, let's jump into it. Good morning, Dr. Hamilton. Thank you so much for coming on Let's Talk SADS Live. So today we want to address exercise with people living with SADS conditions. It's a dilemma for so many of us. We may have heard conflicting advice. We may have some hesitancy because we're worried about triggering our arrhythmia or causing more dysfunction to our cardiac output. How do you address these concerns that you have a pretty busy practice? What are you seeing? What are the concerns that you're hearing from parents and caregivers? Because you have a pediatric practice, but what do you hear in your own clinic about exercise concerns?
Yeah, I mean, it's really top of mind for many of the families, both for themselves and for their children. And I would say the first thing is, it's 2025 and they've often visited Dr. Google, or now Dr. AI, I guess. And it's important to recognize that the exercise recommendations for inherited arrhythmia conditions have really evolved markedly, depending on the condition. And so when you're using those kinds of tools, particularly, AI tools, they often pull from a really broad, range of information going back many, many years, which may not apply anymore. So there's some really nice data now for many of the conditions that we work with and that our families have that are really reassuring, depending on the condition.
And what are some concerns that you have for your patients if they don't exercise at all? I mean, what are some of the health outcomes that you're seeing for, they're 100% restricted, they're not doing anything? What are some of those concerns?
Yeah, I think the first thing is, where is that coming from? Is that coming from, the child, the patient? Is that coming from a parent, or is that perhaps even inadvertently coming from me and other healthcare practitioners, right? What's the source of that information? I think in general, for almost any condition now, that kind of approach of, complete restriction just is not healthy. We can condition, right? Maybe the most severe, catecholaminergic polymorphic ventricular tachycardia, or CPVT. So it's really rare, and it definitely does require some exercise restriction. It certainly doesn't require that you couch potato. And for many of these conditions now, either clinical evidence or preclinical evidence would suggest that some exercise is definitely good for most of these conditions. It's just a matter of how much.
Are you seeing a rise in that group that's not doing anything, a rise in obesity, other conditions that they're getting? What are the outcomes of not doing anything?
Yeah, and so, in our group, Allison Howell, uh, has recently put that data together. And, despite what I think is, reassurance to the arrhythmogenic cardiomyopathy families and patients, they're still restricting themselves. I mean, whether I'm sending, sub,
Excuse me.
subliminal clues to them that I don't think they should be restricted. I mostly, again, it's coming from, internet and maybe old data on the internet. And but they definitely, I mean, we can see as soon as they get a diagnosis, um, their body mass index goes up over the next few years or so, and that's all been well identified. And so I'm not sure how to counteract it, but I just want to emphasize that, particularly in people that just carry the gene, although the adult recommendations in the recent past have been, sort of a two-way recommendation. In other words, most people recommend that you restrict, but not everybody agrees. For children, I go exactly the opposite way. I suggest that they not restrict at all, and that they just maintain follow-up and make sure that if they are moving from being a gene carrier to an affected individual, that we identify it early. I mean, we do recognize that and that's a particularly unusual condition, right? So we think about exercise in two ways. We think about it as a trigger for events, which can happen in all these conditions, or we think of it as actually contributing to the progression of the condition, which is relatively unique for arrhythmogenic cardiomyopathy. And so, if you carry a gene, you're about 60% likely to develop disease at some point during your life, but not everybody. And so it likely, there's about a 60% chance that you will need to exercise restrict at some point. So should you encourage somebody to go into a vocation that depends on them being, having a high endurance? No, probably not. But can they participate recreationally or even competitively while carrying? Probably, as long as they recognize that they are at a higher risk of developing disease at some point. And again, for children, I suggest that we just monitor that.
And do you give any guidelines to the patients or their caregivers about warning signs that they should look for when they're out doing their recreational activities?
I think for all conditions, we recommend that they have a plan in place, right? So, and this is particularly important long T syndrome. We now know from and probably for hypertrophic cardiomyopathy as well. Now know from Rachel Lampert's work that both those conditions, that full exercise is possible for the vast majority of the patients, and simply having a plan in place, making sure that somebody that's with you is aware of your condition, just checking and making sure at the athletic field or wherever, or the sports club, that there's an AED there. Those kinds of things, just in the very off chance that something happened. But again, a lot of patient years of exercise and even highly competitive exercise have indicated that the likelihood of having an event is really small, and probably so small that the additive effect of exercise is probably not significant. You should really essentially do what you want.
Right.
For patients with that rare condition, CPVT, where exercise really brings out events, then what we try to do is identify sort of a threshold heart rate and recommend that patients keep track of that threshold heart rate and just maybe work up to sort of 10 beats per minute lower than. And the use of wearable technology really helps here, right? So Apple Watch, Fit Charge, and any of those kinds of things are useful for that condition, I think.
So
I'm old enough. I was diagnosed 35 years ago. I'm old enough to kind of, I feel, live through this this arc of where we were and now, where we are now. But I was very lucky always to be treated in really large centers. So here in Toronto or in Boston. So my cardiologist always had lots of patients to compare to, busy practice. But for some of our families, they live pretty remotely, and I think the data maybe, they might be the only one or their only family in that community that has this. So, how can someone respectfully come with this data that they found on Dr. Google to say, I could do a bit more, and have that discussion with a cardiologist who doesn't have a big practice, maybe very reluctant to give the go ahead? How would you suggest that patients go to have that conversation?
Yeah. I think the first thing is that, in general, those of us in the inherited arrhythmia field in Canada feel that you likely should be linked in to an inherited arrhythmia program. And, distance shouldn't make that much of a difference anymore, right? Because, I see 3/4 of my patients I see virtually. And because it's a pediatric practice, I see them from all over the province and sometimes beyond. So I think linking into an inherited arrhythmia program is important. Now, programs are busy like every other sort of specialized practice in Canada, but getting into a program and having a regular conversation and having them available as a resource is really important. There'll be a nurse or a counselor or whatever who may be more available to you than perhaps a physician, depending on the practice. The second thing I think that gives your local practitioner somebody to contact, and that it's hard in a busy practice for people to pick up the phone or communicate or whatever. But in Ontario, for instance, we have now a system called the e-consult system, and so if a local doctor wants to ask me a question, they just basically write a few lines in a paragraph. If there's an image to send, they just attach it and they send it, and the e-consults return almost within a day. So the e-consult system is a nice way to manage that as well. So, having somebody local who you're comfortable with and that is there is really important. I think the inherited arrhythmia expertise is, centered in large academic centers, but almost everyone reaches through virtual medicine.
So you said earlier that each one of these SADS conditions has sort of a different guidelines attached to it. Within these segments, how do you determine what the exercise prescription would be?
Yeah. So for the vast majority of patients with long QT and hypertrophic cardiomyopathy, there are no exercise restrictions. You should, other than an emergency plan in place. It's kind of like it's kind of like, should I eat chocolate or should I drink coffee around arrhythmias in general, right? Because for those patients, and this is, non-inherited arrhythmias, people always come to you with that because it's in literature, and, you shouldn't drink coffee, you shouldn't have chocolate and all. If it doesn't specifically cause problems for you, do what you want, right? And the same thing for inherited arrhythmias. So if exercise has not been a problem for you, if it hasn't initiated events or caused you symptoms or whatever, with rare exceptions, you should really consider yourself able to do as much as you want. And Mike Ackerman showed some early data that had, sort of 600 patient years of experience. That's not enough, but it was very reassuring. And now, I never know how to pronounce these studies, but it's either Live or Live QT or Live or Live AM. those studies have such vast numbers of patient years registered now that it's clear that we should be reassuring about exercise to the majority of patients unless they've had a specific problem. The one problem, I guess, is recognizing that arrhythmogenic cardiomyopathy, it can be made worse, start earlier, present severely, be associated with earlier heart failure and so on, with certain amounts of exercise. And the data is not perfect, but it's pretty good that, I always get it backwards, but it's either 650 minutes or per week or 750 hours per year or something like that. But our other problem is translating that for the patient.
Yeah, like what's a met? There you go. Right off the bat.
But then we have tables that tell us what, you know, the met minute or met hour equivalents of a particular kind of exercise is. So, you know, we can ask the patient, what kind of things do you want to do? And, you know, if they have a definitive diagnosis, in other words, they have, you know, they have enough criteria to meet diagnosis, whether they're genetically identified or not, then I think it's reasonable to institute those recommendations, and we can do those with patients. I guess the small nuance is extreme exercise, because, you know, one of the major publications suggests that never do extreme exercise. Another one suggests that you can do little bits of extreme exercise as long as you fit within the, you know, met minutes or met hours per week or per year. So that we're not quite sure about yet, but you know, you can certainly do moderate exercise for a certain number of hours per week. So yeah.
So 2 questions just to follow up. What's a met? And what would be considered extreme exercise?
Yeah, so metabolic equivalent, and you know, they kind of range from resting, you know, doing like two met minutes or to light exercise, you know, 4 to 5, you know, maybe just a gentle walk, moderate exercise, brisk walking, uphill, hiking, badminton, doubles tennis, volleyball, those kinds of things, to, you know, high exercise, and typically, you know, hockey, soccer, basketball, and then sort of extreme exercise. And then there's, separate from that, there's the endurance aspect of it, right? Which often, you know, exposes you to a lot more high intensity exercise, or high static or dynamic load exercise. So endurance exercise would be marathon, or being on a sports team where you're at such a professional level that your coach is, you know, forcing or certainly encouraging and sort of whipping you during practices for, you know, hours per week to get you ready for games, let alone in the game. So those kinds of, that's the kind of endurance exercise that we see. The other thing that we see, which is really interesting, sometimes people just want to exercise to look better, and they want, you know, I'm not a good example, but they want certain muscles, and so you can exercise any muscle, single muscle, as much as you want in these conditions, and you have almost no effect on your heart. So, you know, if you want to bulk up your biceps, triceps, shoulders, whatever, just go do separate weights, do them long enough that the muscle hurts, and that will make it enlarge, and then stop. But you can do it without having any effect in your heart, and you'll notice that you really, you know, as long as you're not trying to do powerlifting, to doing lots of reps of one muscle, you'll have almost no effect on your heart rate, and essentially no effect on your heart. That's
great news. You know, I heard that's in my case, and that's a discussion I had with my electrophysiologist, and she's like, go for it, you know, especially, you know, on this end of the spectrum at 56, you know, I don't want to lose strength as I age. And I was certainly in that category of high performance endurance athlete as a rower. You know, I have ARVC, and I likely exacerbated it, from all that early training. I wouldn't say my coach whipped me, but certainly the environment encouraged a lot of training, many, many hours a week of training. So one aspect that we can maybe touch on is for those of us with ICDs that we may trigger an arrhythmia during exercise and then get a shock. And that certainly feels like the punishment of you've done too much and getting back on the track again, restarting. What sort of advice do you give for your patients, dog, who've had an ICD shock and then are really hesitant to get back to their routine?
I guess the first thing to say is that's not our intent, right? We don't want patients to have inappropriate shocks related to exercise. And children are a particular case in point because they get their heart rates very high, into the range where they overlap with their clinical arrhythmia. And because your heart rate during peak exercise can get up to about 220 minus your age. So if you're 12 years old, you can get your heart rate up to 208, and usually we need to set the threshold for the device a little bit lower than that to be sure that we're catching arrhythmia. So my practice in children is to add some beta blocker. But we don't want to do it in such a way that inhibits exercise, because we know that beta blockers can make it tough for you to run for the bus and those kinds of things. So we typically want to just take the peak off the heart rate. It may be that a new medication that just kind of lowers the heart rate without making you feel tired might work better for that, but I don't think we have enough information on it. That medication is called ivabradine or ivabradine. So that's not the intent. And what worries us is, and you're basically, I think you've really described the, part of the effect of having an ICD shock, even an inappropriate one, and it's psychological. And, we know that if you have, more than 2 or 3 shocks per year, that starts to increase your level of anxiety and makes you prone to depression. And so for all those reasons, we like to try to avoid shocks. Devices are pretty smart. And so one of the first things to do is just try to make them a little bit smarter with your own device, or I suppose at your next upgrade, try to think about ways that you could avoid it, right? So most of these are ventricular arrhythmias that we're dealing with. And so we want to be able to have the device recognize the pattern on the EKG, basically what we call a template of your QRS. And so there are waveform analysis programs in ICDs to try to differentiate sinus tachycardia and other non-ventricular tachycardias from ventricular tachycardias. Of course, maybe the best way is to have a dual lead device where the device has a lead in your top chamber as well as your bottom chamber, and then it makes it the number of algorithms that you can use to try to differentiate sinus tachycardia from ventricular tachycardia are much more and much better. Medication to try to take the peak off your heart rate. If you're a patient prone to atrial fibrillation, most of the time you don't need a shock for atrial fibrillation, and so having devices be able to identify atrial fibrillation, not usually a problem in the inherited arrhythmia group, but in certain groups it can be. So like Brugada tends to have a predisposition to atrial fibrillation. And that brings up another point, right? Brugada syndrome is one of those conditions where your events happen at night, and they don't happen during exercise, with exception is that if you overheat with exercise, they might happen. And so in that case, it's a bit of a different prescription, right? Try to avoid overheating. Dress lightly, make sure that you're well hydrated, exercise in the sun on extremely hot days for that group. But otherwise, that group is pretty free to do as much exercise as they want, unless in a particular patient that exercise is associated with events. But that's almost never the case.
Right. Yeah, that's an interesting point about overheating. I certainly notice it with my condition if I'm playing golf in a very hot and humid day. So I have to be a bit careful. So just to wrap up, what would your recommendations be for people to have conversations with their own cardiologists? What do you suggest that how they go into it, how they prepare, what questions to ask?
Yeah, I mean, there are sites that they can look at. SADS has information. Maybe Hearts and Rhythm Organization. Other sites that provide patient level lay information around exercise and inherited arrhythmia. Make sure the site's reasonably up to date. The information's reasonably up to date, and then take that information and have a discussion with your physician, and all recognizing that both you and your physician ideally should be tied in with an inherited arrhythmia program. Some of the programs, some of the academic programs have specific exercise medicine specialists, and although this isn't the bulk of what they do, they often have some good ideas, right? If you're one of those rare patients where you truly, you're involved in a sport that you can no longer do, I don't know if I don't know if you're okay with me using yourself as an example.
Yep.
But you were a competitive rower, right? And that was your culture. So sometimes think about, if you have to back off, there's sort of a couple of different ways to back off. One is you can become a coach or a referee or a trainer or any of those kinds of things and stay in culture. And people look at that two different ways, right? That one is, this is my culture and I'm still in it. There's a hockey player in an American city that likely has a similar condition and became the coach for player development when he couldn't play anymore. So those are ways to think about staying in your culture if you want. Other people will say, no, that would just frustrate me. And I'm going to go learn something else. Everybody needs to compete, right, in life. I mean, ideally, that's a lot of what life is about. Life is about enjoyment, but it's also about competing, whether it's competing with exercise or competing in other ways. If you end up with a condition where you do have to restrict your exercise, but you really want to compete, think about the kinds of sport that allow you to compete without high output. As an example, right? It's accuracy, strategy. It's a good walk in the woods, which is good for almost everybody. But that's a way that you can compete and have your outlet for competition. Maybe you want to take up biathlon, a little skiing, and if you like guns and shooting at a target, maybe you want to take up archery. Any of those kinds of things where you can still have an outlet for competition, but maybe in the particular case and condition, and probably arrhythmogenic cardiomyopathy is the main one, that you're not doing such extremes of exercise that you're accelerating the development of your condition. All this is going to change with time. I mean, the athletes that I talk to are really interested in gene therapy, small molecule therapy, those kinds of things, which, maybe in the future will allow them to get back. And some of them want to keep their skills up so that if that ever happens, they can get back. It all moves too slowly, but it moves too slowly for a reason, because we want to make sure that we don't make people worse rather than better.
Yeah, there's definitely hope for the future. And that's very encouraging. I mean, even in this time frame that I've been as a patient, I've it seems to move slowly, and yet the progress is always going forward. Well, this has been a really informative episode. We encourage our listeners to listen to part 2 of this, which will be the episode to follow with Janet Omstead. She's a behavior change expert and a health coach, and she's going to give some practical and inspirational ideas to get motivated to exercise. But of course, the public service announcement here is speak to your physician first, get clearance, understand what your limitations are, and get out there when you can and do what you can and have fun. Thank you, Dr. Hamilton. You've been a great friend to the Canadian SADS organization. We really appreciate your long service to us and all the great advice you give us each time. Thank you.